Hello, welcome to the West Virginia University Center for Excellence in Disabilities November Grand Rounds. I would love to introduce Dr. Scott Landis, who is joining us as the Associate Professor of Sociology, as well as the Aging and Studies Institute Faculty Associate, a research affiliate for the Center of Aging and Policy Studies, and the research affiliate for the Leonard Center for Public Health and Promotion. I'm going to go ahead and hand it off to you. Thank you so much for joining us.
Thank you, Courtney, and thank you all for coming today. Is anybody from Fairmont? Anybody at all? My grandparents and my parents are from Fairmont, so I'm partial to your area of the country. Anybody ever been to the Wave Tech pool in Fairmont? Yeah, that's where my grandparents' house was, right behind it. So we would just go over there and go to the Wave Tech pool. Is about the only thing that's good to go to right now in Fairmont. I remember growing up when my grandmother called me one time, and she always used my middle name and first name and middle name. She's like, "Oh, Scott David, we got a Domino's pizza here." And then a week later, or a couple weeks later, she was like, "Oh, Scott David, Domino's is gone. It fell into the ground." And I guess one of the mines had collapsed. And so she was like, "Yeah, all we got now is the Wave Tech pool." I wish I could come be with you all because, like I said, I love that part of the country, but I'm excited to be able to talk to you today. I do not see well, so don't chat questions. If you have questions, just interrupt me. Just turn your volume off, and I'm a teacher. I'm used to being interrupted, so I don't have a problem with that. And so as we go through, if there's anything you want to talk about or ask me about, just go ahead and do so. I want to cover kind of a broad overview of the research that I do on folks with intellectual and developmental disability related to mortality outcomes. My background is I spent the first 10 years of my career in the Atlanta area doing direct services, primarily with young Black men with intellectual disability and HIV. And so kind of cut my teeth in that world. And a lot of the time was spent advocating for health services because it was a time period in the 80s and 90s when medical doctors were not willing to provide care for people with intellectual disability who had HIV. We're trying to make the argument that they couldn't understand the medical regimen, and so it wasn't worth the while. And so a lot of our time was spent trying to address those disparities and see if we could overcome them. So then when I got into the academic world, I kind of continued this concern with trying to understand health disparities and specifically mortality disparities for this population. So I'll give you an overview. And then, like I said, if you've got questions, feel free to ask me as we go through. All right, if somebody can give me a thumbs up if you've got my screen. Good, okay, great. All right, so we know that there's been a lot of improvement over the past 50 years for people with intellectual and developmental disability regarding longevity. And so back in the 30s, documentation tells us that the average lifespan was 15 to 22 years for someone with an intellectual disability. By the time we reached the 80s and 90s, this had increased to 50 to 60 years. So extremely marked improvement. And the improvements are typically attributed to a few things. One, improvements in healthcare access that led to better health among this population. So less spread of contagious diseases until the pandemic. And also, there has been less chronic comorbidities in this population, not necessarily because of better health behaviors and health outcomes, because folks did not live long enough. And so we kind of, the age of death is kind of in that midpoint where you live past 60 and you're going to develop more of the cancers and the vascular related issues. So we don't see as much of that. But the main thing was also the deinstitutionalization. I mean, for a while, a few scholars were trying to argue that deinstitutionalization led to poorer health outcomes. And I think in the early days, I was part of the process in Georgia when we were shutting down a few institutions. And in the early days, that was an issue because there were so few community medical providers willing or trained to provide good care for folks with intellectual disability. But over time, as we saw, with proper training, health outcomes are actually much better in community care than in institutional settings, just because of increased freedom and better quality of life. The questions that I've always had and that I look at in the studies that I'm going to show you is a few things. One, whether this improvement in age of death has continued over time, Or is 60 the top end? Is that as far as people are going to be able to live within this population? And then the second thing that wasn't looked at prior in research is whether this applies to all disability statuses. A lot of times they've grouped together people with intellectual disability and Down syndrome or cerebral palsy. And so we tried to pull those apart to see if there's differences across disability types. So I'm going to show you a few graphs that document the age at death among different disability statuses. So the first one is, this is the group with no intellectual or developmental disabilities. And so this is average between males and females. So obviously females are going to be higher. I think average age of death for females right now is about 82 to 83. For males, it goes between 68 and 70. It balances up and down. And so what we have seen over time from 05 through 2017 is just a real slight improvement in the average age of death among folks without an intellectual or developmental disability. Obviously, we're going to see something really different happen here in 2020 when we get the new data from COVID, but this was the pre-COVID trend where we were seeing improvement in age of death. And we have seen the same things in people with intellectual disability first. From 05, when the average age of death was 60.5, we saw an increase to 2017 where it's up to 63.4. So a gain of about 3 years, which is remarkable. When you look at this general population gain, you're talking about less than a year. And so to gain 3 years is really quite something. What I've got documented here at the top is this is the disparity. And so in 2005, there was an 11-year gap between adults with and without intellectual disability, and that has reduced to 9 years, which is really, again, market improvement. And so something is going well as far as the healthcare services access and treatment for folks with intellectual disability that's continuing to improve lifespan. Still improvement for people with Down syndrome, but what you notice most explicitly is the real severe drop in longevity, that we've gone from 72 years to 63 years, and now for adults with Down syndrome, average age of death in 05 was 54 years, in 2017 was 56.8 years. So again, we're seeing improvement of about 2.5 years over the course of this study, but the disparity that I've got documented up here is much greater. That it's gone from 17.6 years to 15.7 years. And then the last group, we'll see a drop again, is adults with cerebral palsy. And so about 3 years lower than adults with Down syndrome. And so we go from 50 years in 05 to 53.8 years in 2017. Again, across all three disability statuses, we're seeing a 2.5 to a 3 year improvement in age of death over this time period, which is much greater than we're seeing in the general population. So that's the real positive news here, is that prior to the pandemic, something was going really well as far as the services that folks were receiving were really improving the longevity among these populations. However, there still was this large gap. And so that's the question that I have when I'm looking at this is this the top end? Is this as far as people with intellectual and developmental disability can go regarding longevity? Or is there a chance that these disparities that I have documented up here, 11 years, 15 years, 18 years, are actually something that we can continue to reduce? Can we get it so that people with intellectual and developmental disability are living longer? And before I get into that, let me show you just a couple more slides. I went ahead and, this is not in my papers, but I thought you'd want to see this. So this is the disparity, the difference in age of death between the general population and those with disability across all US states. And as you see, the average disparity is right under 15 years. West Virginia is doing quite well. Average disparity is around 12 years. So the best state is Vermont as far as longevity for folks with intellectual disability. You see a first bump up from Montana and New Hampshire and Maine. And then West Virginia is right around that second bump with Tennessee and Massachusetts. If you have an intellectual disability, California, surprisingly, is one of the worst states to live as far as this disparity. You're going to see that consistently across these graphs. Here's the data for Down syndrome. Again, West Virginia is doing quite well. Here's the average, right around 19 years. The disparity for West Virginia, it's about 17 years, about 2 years less. Now, part of this is because adults with intellectual disability are living a bit longer in West Virginia than they are across the US. But the other piece of this that's reducing this disparity is adults without intellectual disability in West Virginia are living less years than adults in the general population across the entire US. So the disparity shrinks because you have movement on both ends. And then if you see cerebral palsy, again, West Virginia is on the lower end, meaning that across your state, adults with intellectual disability, Down syndrome, and cerebral palsy are doing better as far as age of death difference than the overall US average. Like I said, California and Nevada on the top end of this consistently. And then on the bottom end, we see Maine or Vermont and some of the northeastern states. And so, like I said, my most pressing question is to try to dig down and see if we can understand whether this disparity is changeable. Can we continue to reduce it further? Or is there a chance that this is about as far as people can get? And so the first place that we have looked in order to try to understand this is causes of death. When someone dies, I've got audio, somebody's cooking, it sounds like, if you don't mind muting your audio. When someone dies in the US, the certifier fills out the death certificate that records the primary causes of death, in addition to all the other health conditions that were present at the time of death. And these are done sequentially so that we can have an understanding of the disease or illness that started the train of events that led to the person's death, and then sequentially all these subsequent health conditions that unfolded that led to the immediate cause of death. And so, for instance, if someone died of a heart attack, that's not going to be their underlying cause of death. That's going to be their immediate cause of death. But their heart attack was caused by they had some type of ischemic heart disease for long periods of time, and maybe even preceding that, they had hypertension or even diabetes. And so you have this sequential accounting where the underlying cause of death is supposed to be the disease or illness that got the process started. It might have started 2 days ago with an infection like sepsis. It might have started 3 months ago or a year ago or 2 years ago, but that helps us know what is the precipitating event that really caused the person to die. And so when we look within public health realm at death mortality outcomes, we're typically focusing on this underlying cause of death. That's what is reported by the CDC every year when you see news reports on causes of death in the US or smoking and cancer and heart disease. They're talking about the underlying cause of death. It's the best way to get an idea of premature mortality trends, and also to look at prevention so that we can increase age of death. So my big question, what I'll be talking about here, is whether these trends are similar or different for people with and without intellectual and developmental disability. One caveat before I jump into this data to show you is that there is a really bad habit among people who certify death certificates in this country. So you've got someone who's been in the hospital and they've died, and the physician or the nurse practitioner, whoever it is that's certifying the death certificate, meaning the person who's recording the cause of death. What they're supposed to do is identify the disease or illness that caused the death of the person. What happens a lot in this country, and it's not just here, we see this in England and Scotland and Germany as well, is that these certifiers will put the disability as the cause of death. And so maybe you had a person with Down syndrome who had aphasia, and because of that, they developed pneumonitis, kind of chronic infection of the lungs that led to pneumonia. And so they died from that whole process of having trouble swallowing that led to the infections and the pneumonia. But what the certifier very often will do is, instead of identifying these respiratory related diseases as the cause of death, they'll then go and put, well, they really died because they had Down syndrome, or they really died because they had cerebral palsy, or because they had an intellectual disability. What we know is that these are disability statuses. These are not diseases or illnesses. They're conditions, lifelong conditions. And yes, people with intellectual and developmental disability have higher prevalence of certain diseases. This is especially the case, we know, with people with Down syndrome, who are much more likely to have Alzheimer's disease. But the disability is not a disease, and it really is useless regarding public health and prevention measures for two reasons. One is, as soon as a certifier puts down a disability as the cause of death, you more or less have taken that case out of the whole system, because we don't know, just on basic public health information, why the person died. Down syndrome is not the killer. They died from something else, pneumonia, heart disease, diabetes, something like that. The second reason that it's really just not a good idea is because it's highly disrespectful. I know there were many times, like I said, I was working with folks with HIV who I'd be with the family at the time of death in the hospital, and afterwards visiting their home to help them with the insurance policies on their loved one that had just died who had intellectual disability. In order, as many of you know who've had loved ones die, you have to get the death certificate from the funeral home in order to file the insurance claims. And they get this death certificate, this piece of paper, and it would say cause of death, intellectual disability. And it was like a slap in the face to these families. They'd say, you know, we spent our whole life trying to get the world to understand that the disability doesn't define my son or daughter, adult son or daughter. And here the last word from the state is that the disability defines, you know, their entire life, and especially their cause of death. So it's problematic from a public health perspective. I think it's really problematic just from a moral perspective. And it, like I said, it's disrespectful to these families and to these individuals. It also obscures causes of death for this population. So this occurs on 26% of death certificates for adults with intellectual disability, and 59 and 60% for adults with Down syndrome and cerebral palsy, respectively. So this really is highly problematic because it's obscuring causes of death for these populations. Specifically, what it is really hiding are preventable causes of death like pneumonia, and the one that's most disturbing to me is accidental choking. Quite a few of these death certificates that are inaccurately reporting the disability as a cause of death, if you go into the death certificate and revise it to identify the actual cause of death, it's accidental choking. And that's the type of thing that is highly preventable and that should not be obscured by saying, oh, they choked because they put something in their mouth because they had a disability. And so it's something that we've really tried to bring attention to in order to see if we can get not only certifiers to change this process, but also the CDC to change their coding scheme. In addition to it just being uninformative, there's also some concerns that we've uncovered. We know that it happens, this inaccurate reporting, in times of uncertainty, when a physician or a nurse practitioner or whoever is certifying the death certificate maybe doesn't know as much about disability, or they just don't know a lot about the decedent in front of them. They don't have a good medical history on the person. Also, due to what I'm talking about, where people are equating disability as disease, which it is not. But the other concerning thing is that we're seeing racial ethnic disparities in this occurrence. And so adults who are Black and who are Hispanic are more likely to have their Down syndrome or cerebral palsy reported as the cause of death on the death certificate than folks who are white. And so we've got a real racial ethnic disparity going on when this occurs. So I won't chase that rabbit anymore. Just to let you know, when you're dealing with death certificates on this population, you have to do corrections. You've got to identify those death certificates that have inaccurately reported the disability as the cause of death, and then go through a process, and I work with a physician team to do so, of revising the death certificate to identify the actual cause of death outside of the disability. And so the data that I am going to show you is actually after this revision, so that we can capture the entire population and don't miss those cases that were reported incorrectly. All right, So let's look at causes of death. And so this is in the US overall. This light gray, light blue bar is adults with no intellectual or developmental disability. In this figure, the orange bar is adults with intellectual disability. So if we just focus on the orange bars first, you'll see that the most prevalent cause of death is heart disease for both groups. But for folks with intellectual disability, it's heart disease, then pneumonitis. Pneumonitis, many of you know, is long-term, it's infection of the lungs due to long-term problems with pneumonia, flu-like symptoms, and respiratory-related diseases. After that, influenza and pneumonia, then cancer, AD is Alzheimer's disease, then accidental choking, diabetes, and respiratory failure. In the general population, it's heart disease, cancer, and then AD is third. There's what's missing for the general population in between here are some other diseases that are not as prominent for adults with intellectual disability. So the thing that I want you to notice is the disparity. So although heart disease is the main cause of death, it's about 10% less, prevalence rate is about 10% less among those with intellectual disability. Cancer, much lower rate of cancer-related deaths among adults with intellectual disability. I think it's important to note that most cancers are diagnosed post-age 65. And as we saw earlier, most adults with intellectual disability are dying around 61 or 2. So the question remains, is cancer actually less prevalent among adults with intellectual disability because of something related to physiology, or is it simply because this population is not living long enough to actually develop cancer? What you do see most prominent is the pneumonitis and pneumonia, much higher rates among adults with intellectual disability. And these age-adjusted rates are about 24 to 25 times higher, which is outrageous. Accidental choking, about 25 times higher. And so the main thing that we're looking for then, based on this study, is these respiratory-related diseases, specifically around swallowing disorders and aphasia. That's what we're seeing across all these disability statuses. So let me show you West Virginia for intellectual disability as well. And I'll just go back and forth a couple of times so you can see it's not a whole lot of change. Rates of heart disease and cancer are a little bit lower for the general population in West Virginia. You see accidental choking bump up a little bit for adults with intellectual disability, but the pneumonitis is going down by about half. Cancer has gone up a little bit. Influenza and pneumonia has stayed about the same. So overall, as far as rank order, there's not substantial differences. And again, as with the general population, the big disparities are around the respiratory related diseases, pneumonitis, pneumonia, and the choking related deaths. It's a very different story for adults with Down syndrome. The primary cause of death is Alzheimer's disease. Now we know that because of the trisomy 21, that adults with Down syndrome are more likely to develop APP and the tau tangles in their brain as early as age 30. And the research tells us that by age 50, 90 to 95% of this population has the brain physiology related to Alzheimer's disease. And about 50 to 60% of this population is developing Alzheimer's disease related symptoms. So you might be surprised to see this at only 20%, but remember, this is not whether Alzheimer's disease was present at the time of death, but whether the certifying physician identified it as the underlying cause of death, the thing that led to the final death of the person. So Alzheimer's disease, and then heart disease, and then again, we see these respiratory related disorders, pneumonitis and influenza and pneumonia. So the real shift here is in this rate that is 5 and 6 times higher if you look at age adjusted than the general population. Again, I'll show you compared to West Virginia. So here's US and here's West Virginia. Again, you see heart disease go up a bit. Alzheimer's disease comes down some for both groups, but more so for adults with Down syndrome. Influenza and pneumonia stays about the same. And the pneumonitis, again, is reducing by about half, which I don't have a reason for this. I've not been able to look into it, but we've seen this now for both. This should be, you know what? I was on the wrong slide, wasn't I? Here we go. I was going intellectual disability, my bad. Here's Down syndrome. AD comes down. Let's look at the pneumonitis. Yeah, it goes down by about half again. Again, I don't know why. And then cerebral palsy. So we've got much lower prevalence rates, again, as we did with intellectual disability for Alzheimer's dementia. Heart disease is high, but you see influenza, pneumonia, and pneumonitis as leading causes, or this second, just right at second, but much higher rates than we saw among the two previous disability statuses. And we know because adults with cerebral palsy are much more likely to have aphasia and swallowing related disorders. And because of that choking mechanism are more susceptible to developing pneumonia and lung related infections. Accidental choking is about at the same level. And again, compared to West Virginia, and this is a little bit different than the prior two, we see heart disease among adults with cerebral palsy increasing about 4%, influenza and pneumonia going up a little bit, but the main difference is really in this heart disease that goes up here, whereas in intellectual disability and Down syndrome, it reduced a little bit over time. And so just to give a broad summary, we've seen improvements in age at death, but there still are pretty substantial disparities. 9 years for adults with intellectual disability, 15 years Down syndrome, 17 years adults with cerebral palsy as far as dying younger than the general population. And so going through these causes of death, the most prominent factor that is preventable is pneumonia and pneumonitis, these respiratory related diseases, and then also the accidental choking. There's been a push lately within some of the academic literature, and I don't know that it's made it to services, I hope it has, to give increased emphasis to swallowing hygiene, to the composition of foods that are being served for meals, for folks that are receiving services, making sure that food is cut into small enough portions, and also to trying to help folks with intellectual and developmental disability as much as possible learn to pace eating, to chew, masticate before they swallow, with the theory being that many of these cases of accidental choking or long-term pneumonitis could be prevented if we can prevent the frequent occurrence of choking during mealtime. And so hopefully that's made it to service-related level. I don't know if y'all seen that across the state or not. But that is the biggest takeaway, I think, from the studies that we have put out here, is that we need to be putting more effort into reducing these respiratory related disorders, especially preventable ones. The other thing, and this is what's, I think, most disconcerting, is that many physicians, primary care physicians that are providing care for adults with intellectual disability, as you know as well, have not been properly trained, not only as far as communication in order to make sure they're providing the best care for adults with intellectual and developmental disability, but also regarding these comorbidity patterns. I mean, because any physician providing care for an adult with one of these disability statuses should be giving primary attention to respiratory related disorders, to lung capacity and infections, but also to swallowing, and making sure that the individual and or caregivers are having the appropriate training and reminders about this. There's been some recent publications by Lisa Azzoni at Harvard about physicians simply assuming that because the person has a disability, they're going to have worse health. There's just no way around it. And so what we're really trying to do is push back and say, no, that doesn't have to be the case. That a disability is not equated with poor health. It only leads to poor health if the medical care and the care is not appropriate in order to account for those disease patterns that are more prominent, or those preventable diseases that actually can be addressed through better care or better attention to specific concerns. The big question that's hanging out there is COVID. And we're all waiting for the CDC to finally release the 2020 data. The CDC typically would have released it by now, but they seem to be hanging on to it longer because they want to play with it themselves before they give it to the rest of the world. So once they actually release data, we'll be able to see what's going on. But I just want to briefly go through some of our early analysis on COVID. And I'm sure you're seeing very similar things. I don't have data from West Virginia. The state has not shared that yet, but we've been able to look across the US at some different data sources. We were concerned going into the pandemic, as many of you were, because we're talking about a vulnerable health population. We know that a disproportionate percentage of people with intellectual and developmental disability live in congregate settings. Estimates are 16 to 20%, which if you think about adults that are 65 and older, only 6% of that population live in nursing homes, congregate care. And so the 16 to 20% is much more disproportionate when we compare to the general population. And because of what I've just documented for you, that these co-occurring conditions, especially these respiratory-related disease deaths, are much higher in this population. So our expectation going into the pandemic was that we would see the same thing with COVID-19. Our early evidence from our studies are that there was a higher case fatality rate, especially at younger ages for adults with intellectual disability. Case fatality being the rate of death among those people diagnosed with COVID-19. What we confirmed in data from New York State is that this is especially the case for adults living in group homes, which in my mind makes total sense, because I don't know what it's like in West Virginia, but in New York State, you can have up to 15 people in a home. And so if you account for 15 residents plus a staff rotation of 20 to 25 people, you're talking about 40 people in a shared congregate setting during the course of a week, many times with the group home staff working second and third jobs. And so especially at the beginning of the pandemic, where there was just extreme spread of COVID-19 across the group homes in our state. So we see a higher case rate, but we saw case fatality rates that were outrageously 2 and 3 times higher than the general population, especially from the period of March through November of 2020. Post around October, November, we started to see a real drop, but that was about the time in our state where the state had really clamped down on visitation, on day hab, on things like that. And then what we were able to confirm in California data is that there's a real difference between folks living in group homes and those living in their family or their own home. What we saw in California is for adults with intellectual and developmental disability living with their parents, or living independently in an apartment with a roommate or with a partner or a spouse, actually doing just as well as the general population. We were seeing that it was only those living in these group homes, and especially if you were receiving nursing care, so in an ICF or in some type of facility that provided either 12-hour, 24-hour nursing care, which would indicate higher comorbidities. And then we finally, our last report on the case fatality rates, we were able to look at 12 states, or 10 states plus 11 states plus DC, and a similar pattern across all 12, where folks living in group homes really were not faring well during the pandemic. People in their own home or a family home were doing quite well. So it really, to me, speaks to and gives more evidence stating that if we can, as much as possible, it's going to be necessary to shift over time as much as we can away from these group settings, more towards independent care settings or support. The big questions that we had lingering, and we addressed in our last study, is whether the predictors of COVID cases and COVID deaths are similar or different for adults with intellectual and developmental disability in the general population. The CDC tells us get cancer, chronic kidney disease, COPD, heart disease, obesity, smoking, diabetes are predictors in addition to age. We were wondering about type of residents, number of residents, and disability status. So for this study, we used data from AHRC in New York City. It's a large provider that serves 25,000 people total across the city. And during the course of the pandemic, they had 543 people in residential settings, spanning from ICFs to supported living, where it's just you and your apartment and staff is dropping in. So we looked at their data from March through October of 2020 to look at COVID positive status and death. And as you would expect, increased age was associated with higher likelihood of actually being diagnosed with COVID, as well as number of residents. The relationship was not severe here, but it was significant, where if you lived in a setting with more residents, more likely to contract COVID, which again makes sense on both cases. And then here's some other characteristics. Sex didn't really predict. Racial ethnic minority status actually did predict, but in the opposite direction of what we expected based on the general population, where in the sample that we have, the racial ethnic minorities were less likely within this setting in New York City to develop COVID. Type of residence mattered. Folks in ICF were much more likely to be COVID positive. Was not the case in supervisor supportive, where it actually went the other direction. The big predictor, though, was Down syndrome, where adults with Down syndrome were about 2.5 times more likely to be COVID positive. And then for the comorbidities of cancer, chronic kidney disease, and COPD. That's bivariable. When we looked at multivariable status to offset for age and comorbidities, the only predictors, and not surprising, like the general population, older, and this looks small, but this is for each year increase in age. So this really grows quite a bit when you get into older adults in their 60s and 70s. Age was a big predictor of COVID status. Also number of residents. Again, this is by individual count, so it grows when you get up to 15 residents. These were 2 predictors. Those in the supervised settings, the group homes, were much less likely to develop COVID than those in ICF. ICF was the category that had the highest COVID rates. And then the Down syndrome was 3.5 times more likely, folks with Down syndrome, to develop COVID, and then folks with chronic kidney disease. We then turned our attention to mortality. And really the storyline here is heart disease, that once someone developed COVID, that if you didn't adjust for age, it looked like cancer, COPD, and heart disease all predicted whether you were going to die from COVID or not. But once we adjusted for age, it really was all about heart disease. Close to half of those who died in this setting in New York City that we were looking at had heart disease prior to the pandemic. And that's actually the primary predictor. Age was close, but even once you account for heart disease, age was not a predictor of COVID status. And so looking at COVID status, we found similar predictors: heart disease, cancer, CKD, and COPD. But the really unique ones are number of residents and Down syndrome. And what I often say to people is there's only one of these that you can change. You know, once you have heart disease, cancer, chronic kidney disease, COPD, and Down syndrome, I mean, these are lifetime diseases and a lifetime disability. And so it's not likely that we're going to be able to change any of these. And you can maybe improve health treatment and health outcomes for people who have these specific diseases. We can change this. And so to me, this is one of the biggest takeaways from these studies that we've been doing, is if we want to improve outcomes for people with intellectual and developmental disability during a pandemic, yes, but also during flu season, during any type of time period where we're seeing the spread of respiratory related diseases, we're going to have to start addressing number of residents. I mean, like I said, in this state, it's 15. I know the state's cutting the budget across the board 25% for intellectual and developmental disability services. The scuttlebutt is that they're going to jack up residents and take it up to 20, to allow 20 per home. And what we're trying to advocate for and argue is that it's going to mean death. I mean, more people are going to die with intellectual and developmental disability, not just during the pandemic, but during any subsequent outbreaks of some type of contagious viruses, or even during flu season, if we continue to jack up these number of residents. What the data is showing is that people with intellectual and developmental disability are much more likely to die of respiratory related diseases in settings, especially where there's more residents, higher congregate interaction. And if we want to improve that, we're going to have to really bring this number down. I'm not going to talk about that as much, about vaccine hesitancy. One of the biggest problems, and I was hoping to maybe see if you'll have insight on this, is that states are not sharing data. We know that 48 out of 50 states, including West Virginia, have been collecting data on COVID-19 for people receiving Medicaid waiver services during the pandemic. And to date, only 12 states have been willing to share the COVID-19 data. And so what we've been arguing is that this is unacceptable, that if we really want to improve outcomes for this population, data is going to have to be transparent so that public health experts can look at it and say, okay, here's what's going on and here's what we can do in order to address the concerns that we're seeing during and post-pandemic. In addition, HHS to date has not been willing to require states to report data. There's been some movement in Congress to get HHS to do so, but to date, it's not happened. But my hope is that they'll actually turn the corner on that. The big question, like I said, is not going to be answered until we get the CDC data. Because across the board, disability or not, we're going to see probably an extreme dip in age of death in all populations because of COVID, and a real shift in primary causes of death, with COVID going up towards the top is what we're assuming based on the early data that we've seen. The question is going to be a couple of things. Number one is, do we see the same patterns among adults with and without intellectual and developmental disability across the US? Or is there a chance that the higher rates of death in these group homes is going to make it so that the effect of the pandemic on age of death is much more severe for folks with intellectual and developmental disability? That's what our preliminary evidence is saying. We're going to have to confirm that once we get the CDC data. The second thing, though, is going to be non-COVID related deaths, whether we're seeing excess deaths that aren't COVID related, simply because people had less interaction with their physicians and less access to healthcare during the past 18 months. My wife works on a spinal cord injury unit at the VA Medical Center here in town. And I know in their case, they saw very few deaths during COVID from COVID. But since things have opened back up, they have had 8 to 10 deaths every week for the past 8 to 10 weeks. The reason being that many of these veterans did not come in for their annual evaluation during the COVID time period because they were concerned. And because they didn't come in, there were some wounds that were missed. There were some respiratory infections that were missed. And so people are dying from preventable causes of death within the population she serves, not from COVID, but because secondary to COVID, because they didn't receive the care that they needed during the pandemic. And so the question is going to be, when we finally get this data, is not just the COVID deaths, but do we see many excess deaths from heart disease, from pneumonias during this past year and a half due to less access to medical care and possibly less monitoring, not only by agencies, but by states. All right, I'm going to stop here. Open up if there's any questions.
I have a question. Why are doctors not recognizing that, the Down syndrome and all that are actually dying from a disease and not just the symptom itself? Why are they not recording that?
That's a good question. From what the interviews that we've done, a lot of these physicians received no training on developmental disability during their time in medical school, and very little training post once they start practice. And within the medical community, there still is that old school idea that disabilities are health problems. And that's not just developmental disabilities, that's spinal cord injuries and other types of physical disabilities that everything is viewed through that medical perspective. And so there just has not been the same differentiation between health and disability among medical practitioners that we've seen within the disability community, among advocates, and also among care providers. In states and also in medical facilities where you have increased training, physicians are much less likely to do this. And so our contention is this really is simply about education and training, that there are that many medical providers who have not had the exposure they need in order to make the simple conclusion that we all know is true, that disability and health are distinct. Might be interrelated, might influence each other, but are distinct things, and that disability is not a disease. I think there's movement towards understanding, but there's just a long way to go. The last survey shows that there are only 6 medical schools across the US that provide any training in disability during the med school process. And that's just, it's unacceptable. But that's what I think leads to this.
That's pathetic.
It really is. It is.
A question was asked if a copy of this PowerPoint could be available to us.
Yes, I think Leslie's got one, but I added some of the COVID stuff. I can send you, whoever wants it, I can send it to you and you can distribute it.
Great, thank you. Are there any other questions regarding the material or any follow-up questions regarding the response to the question that was just asked?
I have a question related to the slide where you showed the odds ratio. I just want to make sure I understood you correctly. The odds ratio where it indicated the supervised settings. Yeah, okay, so supervised settings, are you saying there that the incidence of positive COVID was low? I just want to verify that, as well as in the ICF. What was the comment about the ICF setting?
Yeah, so in this graph, a good question. ICF is our reference category. So I'm comparing supervised to ICF. And so those in the supervised group homes had lower COVID case rate. I mean, supervised, not the group homes. I'm sorry. Make sure I've got the wrong. Yes, the supervised of the group, I always mix this up. Supervised with the group home, supportive was the apartments. So in the supervised group homes had lower spread of COVID than the ICF setting.
Okay.
So in this, yeah, in this, for this provider in New York City, the spread was worse in ICFs, which in my mind totally made sense because a lot of people they had in their ICF settings had pre-existing respiratory related conditions and need for very intimate face-to-face care that in the early part of the pandemic, when PPE was not available for these providers and they were having to improvise and beg just to get bandanas to tie around their faces.
Yeah.
The spread really was high here. Supervised settings, the group homes, it was still higher than the general population, but less than the ICF.
Yeah. And I guess I found that telling to a point. I'll be honest and say that I'm a nurse and I've done a lot of work through my years in developmental disabilities. And I appreciate, the comments about group home settings because yeah, it's inherent in some sense that when you're around a lot of people with whom it can be challenging to explain physical distancing, to explain coughing and sneezing and washing your hands. It can be challenging at times to explain those things.
Right.
But I also recognize that in the grand scheme of things, we're dealing with a population that at the outset of COVID, there was very little regard for the needs of this population. So we were extremely low on the totem pole when it came to any kind of education, any kind of support, any kind of access to PPE, recognition by public health departments that we were out here. And so I think there's a lot of dynamics that play into the picture that I think I'm a little hesitant to just kind of all of it, just throw it all in the idea that it's the congregate setting that did it. I think it's the whole picture about developmental disabilities and how folks with developmental disabilities are treated. And I think it's a larger issue, and there are many smaller issues, but it's a larger issue there that still needs to happen in terms of changing the paradigm of thinking in the society about the value of people with developmental disabilities and what they can contribute within their communities and so on. So it's a huge bucket, really. But I appreciate the breakdown that you were able to achieve there. Because I do think that if we do have group settings, that there's something to be said for supervised group settings based on what I understood from your data there, in that we don't necessarily have good supervision of DSPs and direct caregivers in these settings. And they come from a variety of perspectives. And there's been challenges with regard to just trying to have them appreciate vaccination. And that's been a kind of a tough issue. So I just kind of think about all these little factors that play into that whole big COVID picture. But I do think that, and I guess I don't want to sound too biased here, but I do think that there's something that nursing can bring to these settings that is not always appreciated, because there's still this historical stigma about the larger institutions, and nurses kind of get equated with that. When in fact, we as nurses can bring a perspective of health and health promotion into the picture. But again, there's so many dynamics. There's the politics of it. There's the capacity to pay nurses. There's all these kinds of things that play into whether it happens or not. But I just kind of throw that all out there because it's such a complex issue, and not maybe as black and white as we might desire it to be. So thank you. I wanted to say too, I thank you for your presentation. I appreciate your breakdown of the data here and really trying to be as accurate as you can, because I've seen death certificates too, where they think it's the disability that caused them to die when in fact it was really other factors. So thank you for your work.
And I don't disagree with you. I actually spent 3 years working for an agency that we had 20 group homes across the state of Georgia. I think group homes can be done very well. And there are some group homes, I mean, I am in close contact with quite a few across the country that had very low outbreaks for COVID-19 because for whatever reason, they were able to get PPE earlier in prioritization. I think it becomes, at least in a state like New York, it becomes problematic though when we're reaching the 15 or 20 residents in a home, especially when you're doing 8-hour staff shifts and you've got 25 and 30 staff coming. I mean, it's like a nursing home. There's going to be no way that you can truly prevent spread. And I think the other factor, and you were talking about it's being complex, and it is, at least in this state, is the low wage for DSPs is really forcing them to go to second and third jobs in both urban and rural areas. And so then you can't control. I mean, I know in the New York City area, the CEO was saying to me, my biggest problem is that 3/4 of my DSPs do second shift night shifts at LaGuardia. And so as COVID was coming into the country, they were bringing it straight into my home in the next morning. And he said, what can I do about that? I think the other concern that we've really had here, and it made the news for nursing homes, but not for group homes, is policy-wise, our former governor chose to make some decisions that covered up the amount of cases and deaths we were seeing in nursing homes. But it was also the case with the group homes, where the state refused to share the data. And the state also made a decision that when someone was COVID positive in a hospital setting, being discharged back to a home, that they required the group home to take the person back in, but refused to provide them extra money to provide quarantine wards. And so you're just bringing somebody into the room with their 3 or 4 roommates, and then boom, everybody had COVID. So I agree with you. I think the disrespect that people with intellectual and developmental disability have received is just as its fault during the pandemic as anything else that we see going on. I think you're right.
Thank you again for your work. Appreciate it.
Yeah, thank you. Other questions? My big question is whether WVU is staying in the Big 12 or not. Are they finally going to have some sense and come to the SEC? I'm from the South. You know, we'd love to have them in the SEC. Or do you want to keep traveling to Texas every year? No one is a WVU fan. That's not good.
Someone
I'm
just
all
said
for
a
moving
Okay.
to the new conference. But
Okay.
I'm an attorney with disability rights of West Virginia, and as an advocate and somebody outside of being directly inside the medical, system, how do we make this happen? How do we get doctors who tend to be very sure about what they know to be true? How do we get them trained on this? What can people as advocates do to support and encourage that training? I mean, what can we do about this, basically, is my bottom line question.
The movement that we're seeing is that finally folks with disability are getting into med school. Self-advocates. That's been these programs that have training, if you dig into them, it's a lot of times because they ended up having students 3 or 4 years ago with some type of physical disability who was willing to speak up and raise awareness and say, wait a minute. Now, the difficulty is that training then becomes about physical disability first, and they don't get to developmental disability till later. But that's the two strategies that we have found most helpful. One is if you can get a med student that speaks up, but even better is if you can get an ally among the staff. And so like at our med school here in town, Upstate Med Center, which is a SUNY school, one of my primary collaborators, Peggy Turk, has been doing research on this for years. And she doesn't let a staff meeting pass where she's asking the question, well, what about developmental disability? What does this mean for our folks who have developmental disability? And unless you have an administrator that's willing to sign on board, it takes that vocal staff who's willing to be a pain in the rear to say, we've got to really start including this. I think that's the front end. The thing that I cannot get a handle on of how we can address is for people who are done with med school, because all the attention goes to the training. But once people have finished practice, what do you do? Because AMA is paying no attention to this. I mean, they just act like they don't care. And the doctors that are attentive get treated like they're developmental disability specialists, and so we really don't have anything to do with you. You treat yours, we'll treat ours.
Yep.
So I don't know the answer to that, and I don't know what it's going to take to shift it. But to me, the AMA is the big dog that's going to have to be addressed. That until they somehow, we were pleased that we were finally able to get one of these COVID articles in JAMA, because they just don't publish on developmental disability. So I don't know, maybe we can build on it, maybe not.
I would just like to add that I think that it's not just a doctor's thing. As a social worker, there's not good education around disabilities in that area. I think it's something that's just barely glossed over across the board in most fields, and that's an issue, I think.
I think you're right. I think across the board.
I'd like to share that. Oh, excuse me.
Oh, no, go ahead.
I'd like to share that there is a professional organization called the American Academy of Developmental Medicine and Dentistry. And they have been really trying to push the medical health education for several years now. They are working on a curriculum. One of the challenges in the medical schools is just trying to get it in the curriculum, only because the curriculum is already so packed.
Right.
And so thinking of different ways to integrate it, and in the sense of inclusion, in the sense that instead of having, this is the course on developmental disabilities, it's more like patients that you encounter, and giving the students the opportunity to be exposed to people with disabilities in the course of, say, a med-surg rotation or a psychiatric rotation or something of that nature. So it's not like again, we don't necessarily want to encourage separation. We want to encourage inclusion. So the idea is, here's the span of patients that you might see, and think about how do we encourage or incorporate people with disabilities into that education. There's such a thing as a standardized patient approach, where people with disabilities, if they're willing to volunteer, some medical schools actually have this set up where you can be a patient, and ideally, if you don't necessarily want a non-disabled person or more a typical person to portray a person with a disability. Ideally it's somebody with a disability that is that patient, and then the student gets this real interaction with a person with a disability within the context of their learning experience that's already on the curriculum. You don't have to create anything new. It's already embedded in the curriculum. So there's different things that we're trying to do in the healthcare education realm, and we're trying to do that in nursing as well, and get it integrated as much as possible. Admittedly, it's been many years. It continues to be a challenge, but I think in many ways, COVID has opened the door to having
Yeah.
these kinds of discussions because we're recognizing the disparities that we maybe didn't pay much attention to before, and we're just having to take advantage of this opportunity to have these kinds of discussions.
There's a Lisa Meeks at Michigan and Bonnie Lynn Sweener at Johns Hopkins are part of an organization called Docs with Disabilities that they're really pushing, because they both have disability and both are MDs, and are saying that you shouldn't, you've got to have this training. I think the real challenge is going to be, though, that as we saw in the disability rights movement, that the focus is on physical disability. And so it just, the main movements are really not even, they're just addressing physical disability, not developmental. And so I think that's going to be the concern, is because you're not going to have med students or physicians typically with an intellectual developmental disability being able to speak up for themselves, whereas docs with physical disability or nurses can. And so how do we get that advocacy and in the door, especially around this issue, is the real challenge.
Okay, well, I know that we are right a few minutes after, so thank you so much for your time with us. If anybody has any additional questions, feel free to send them to us and we can send them over to you. You can answer them. And I put a link in the chat if you take a moment to just make sure that you fill that out. It's just an evaluation on the experience today. So thank you again so much for your expertise and your time.
Thank you all for attending. Bye-bye.